Stethoscope, and I've got some venous pulsations you can see. I'm not going to go start to finish through the whole exam. We're just going to kind of go piece by piece, you know, really things that are important. But mostly you need to know where to put your stethoscope. And then how do you do a hand grip? How do you do an Valsalva when you're looking for murmurs? Everybody knows what left lateral decubitus means, right? Just laying on your left side. So to go back to our exam, first thing you're doing is looking. So you're going to, you know, you're going to tell your SP, I am inspecting your skin. I don't see any pallor or cyanosis. You appear to be in no distress. You appear to have normal breathing rate. I mean, just any normal, whatever normal is happening. Okay. When you inspect the neck, the first thing you're just going to inspect their neck with them. We're going to start the exam with them upright, because in the real world you've already just listened to their lungs, so they're already upright. So you're also, when you're listening to their lungs, you could be inspecting their neck at the same time, okay? And so you're just looking for any engorgement, and you're going to kind of look right at the clavicle, because the internal jugular is going to be right in that area. It's the same place you can put a central line in someday. You can, or a jugular line. Yep. J, I guess. So you kind of look in that area. Her carotid is going to bound up here. You might be able to see it, you might not. Tilt your head. You ask the patient to tilt your head a little bit to the left. And then just kind of look in that area for the carotid pulse, and then down here for any venous pulsations. With them upright, you really may not see much on the venous, because gravity is pulling the blood column down. So that becomes more important. And I put on your checklist, you're going to look at the neck again when you recline her back to 45. So, but you just finished listening to her lungs, so as you're starting your cardiovascular exam, you're looking at her neck, you're looking for any cyanosis. You can check pitting edema if you need to. You can check for pallor on the hands. In a perfect clinical setting, she's in a gown, she has a sports bra on. We'll be able to slip the gown off so that we can see the chest. Your SPs will have sports bras on so that you can keep some amount of modesty. But in a perfect world, you would have the patient topless so that you can see the apical pulse. But we're going to protect modesty for our SPs and for professors.
In your clinic, you're not going to have them get naked.
Right.
So you're going to have maneuver around their clothing as well, and you're going to have to be able to do that comfortably, as well as you not being able to see where their stethoscope is, but use your fingers of knowing where you're at on their body. Because you're going to reach up and you're going to ask them and tell them, I've got to really get in to listen to all of the heart sounds. So I'm going to reach up underneath your shirt so that I can get my stethoscope on your skin and not miss anything. I'm going to be lifting up, or can you lift up your left boob, one way or the other? Okay.
I mean, some women, you'll have to have assistance in that. You'll have to ask them to lift their left breast up, you know. I mean, it's funny, it sounds funny, but it, you know, it's true. So after you've inspected the neck, I always start with the bell, and I think, or I start with the diaphragm. I think that's what I put on here, yeah. Okay. Now, again, I also put in italics there, verbalize to your SP that I'm examining the chest, I'm inspecting the chest, I'm looking for the apical pulse. It appears normal. Had your patient come in with chest pain, you would palpate the chest, but we should have done that in the pulmonary exam. But for the sake of an SPBL, if you have a SP come in, they have chest pain, at that point you want to, at some point between the pulm exam and the cardiovascular exam, you want to palpate the chest wall, the sternum, the costochondral joints. We do it with 2 hands and squeeze. I like to do it with my fingers, just right on where they say is tender, but there's no right or wrong as long as you're palpating it, okay?
And we're doing that we're doing the pelvic exam as well, right?
Well, we're going to have, it'll be a focused SPBL, but as you'll learn in PA school, at a minimum of every person that comes in, you're going to do a lung and chest exam anyway, a lung and cardiovascular exam on everybody, no matter what their complaint is, even if it's toe pain. So, yes, you will have already done that. And the 2 exams they start to run together, which, some textbooks, they don't even separate them out. It's called the chest exam, and it's all of it. So, the two are going to run together anyways, so, yeah.
If you do elicit pain with that compression, it's called reproducible because you can make that pain reoccur or increase, which would rule out cardiac. Because cardiac pain is not reproducible.
Mm-hmm.
So then you're thinking pleurisy, pericarditis, not pericarditis, I'm sorry, costochondritis,
arthritis, something like that. Arthritis. Okay. So when you listen, start with the diaphragm. And so you're going to, I always start with the aortic position. Do you start with the aortic position? It doesn't, I think I have it listed as to start with the aortic, but to start on the right. So you'll be about here. So if that's the clavicle, you're about the second intercostal space. And listen for a while. And the way I have it on your checklist, listen with the diaphragm in all the positions, and then we're going to come back to the bell in a minute. So then we'll do pulmonic, which is just directly across in about the same space, second intercostal space on the left side. The best place just for a normal heartbeat is right here. It's just because it's where the stroke volume is coming right there. So then when you do tricuspid, you're going to be about here. You can still hear that. I can hear it just fine through your clothing, but you need to be skin to stethoscope. Then I'm going to say, Dan, could you lift your left breast for me? I'm just going to go over the clothes. And so she can help you lift right there, and then you're going to lift right here. For her, because she's big busted, you're not going to get right in the perfect position. There's just no way to get there. So you just have to have her lift, and you just try to get as close as you can. You can still hear pretty good, and I'm not even on the skin. Then you want to listen for any radiation over here. So. Then you're going to flip to your bell, and you can tell the SP, okay, I'm going to listen now with the bell. And then I would, at a minimum, just listen in the aortic position. Here, with the bell. And remember when you use the bell, just to put it down very light. Don't press it down too hard, it turns into a diaphragm. And then, for the purpose of grading, at least 2 positions with the bell. So always this one, and then again, so I can lift your breast on me. I'm going to listen with the bell in the mitral position. So comfortable with telling the patient, help me out here, work with me, it's okay, and explain everything you're going to do. A lot of times in real life, just put my stethoscope up underneath their shirt. I like to be on the skin, but instead of having everybody stripped down in clinic, I'll just kind of say, I'm going to pull your shirt out and put the stethoscope up underneath. And that's perfectly fine as well. If they have an underwire bra, though, you're going to have to ask them to move their underwire out of the way so that you can get up into that mitral or apex position. Okay. So again, listen to several cardiac cycles in each position, because like we heard on the recordings, sometimes you won't hear it every beat. So if it's splitting or if you're hearing it just may not occur every time. So listen to several cardiac cycles before you move on to the next one. Okay.
Your aortic, and when you do the mitral, there's also the special test that you need to listen there for a little while and then have the patient lean forward.
I skipped over that. So, and that's with the bell.
Correct.
Yeah. Okay. So when you're listening to that mitral position, listen for, several cycles and then ask the patient to lean forward. And that will sometimes bring out those mitral murmurs. You could, and if you're doing an extremely thorough cardiovascular exam, you'd have them lay down and listen to the mitral position in the left lateral decubitus position, but for the purpose of SPBLs, they're not going to have everybody do that. But that's just something you need to know. If you hear a murmur in that position, you definitely need to listen to it in the left lateral. There are some mitral murmurs that will only come out too when you're in the left lateral. So really, if you want to do an extremely thorough exam, that should be part of your exam. But we're not going to do that for the purpose of assessing you. Okay. Okay. So we still have the stethoscope out, and we're still going to auscultate. But we're going to do bruits. So at this point, we would recline her to 45 degrees. And then that also gives you your second opportunity to look for jugular venous distension. Okay. We obviously don't have a table in here where we can recline her to 45 degrees. But that's what we would do. You would look again at the neck and verbalize to your SP, I'm examining your neck again for any jugular venous distension at 45 degrees. I don't see anything abnormal. Okay. Just for the sake of time, I'm not going to show you exactly every single position to listen for a bruit. To me, it seems pretty self-explanatory. We're not doing temporal arteries, so you don't need to listen to their foreheads, but you want to listen with the bell to both carotids. And remember, when you use the bell, make sure you have it rolled, and then make sure you apply it lightly. If you push too hard, it changes it into a diaphragm. If you're having a hard time hearing it too, you can have her take a deep breath in and hold it. So you can hear the vessel a little bit better. They can breathe. Rather than hearing her breathe, you can actually listen for the breathing. Okay. So I'd usually listen with them breathing first. And then if I'm not quite sure if I heard everything, I'll just say, you take a breath in and hold it for me. I don't hear any abnormal sounds. Okay. So, again, she's reclined 45, right? So we listen just midline abdomen for an aortic bruit. Okay. You're going to listen to both her iliacs, both her renal arteries, both her iliac arteries, and then you're going to verbalize. At this point, I would listen to your femoral arteries bilaterally with the stethoscope, with the bell. But you don't have to do that to the SPs, okay? Those are the only positions you need to auscultate for bruits in, but when we palpate pulses, we'll palpate all the way down, okay? Go ahead, Jen.
If you're having a hard time auscultating the carotid, palpate first, and obviously you're going to do one at a time. So literally I would have my stethoscope ready, palpate, and right where I'm feeling it most is where I would place it so that you know that you should be hearing something there. Okay. That's the only thing that I would
The other thing too is don't get real aggressive with the carotids. You can actually throw somebody into a block by doing a carotid sinus massage, harden up. So just be gentle in this area. The other thing is, what if you've got an 88-year-old little old lady who's got an artery full of plaque, you know, and you go ram around her carotid real hard and she has a stroke, you know. So just be real gentle around the carotid arteries, okay? It's also a sensitive area. I don't know about you. I don't like people touching my neck or my face that much, especially if I don't know you. So, you know, just be real gentle around that area.
Claustrophobic people and anxiety people, definitely talk them through that. I'm gonna palpate your arteries on your neck, and you can touch yourself so that you're showing them where you're going to. Because if you just go at them like this, they'll be like,
Well, and I've heard practitioners before saying, you know, like just stand in front of the patient so that you're palpating this side and then you're palpating this side. You're not, especially if it's an anxious person, you're not going like this and like feeling like it's on their neck or something. Especially if somebody that's been raped or abused, or that could be very anxiety provoking. So we're trying not to, you know, push on their neck and like make them really uncomfortable. So it's okay to do it from one side, but if you do, just be sure you're moving your hand around like that, that you're not giving them the chokehold. Okay. So again, when you're palpating artery, what are you thinking about? What do you want to know? Intensity, symmetry. Yeah. So, and your contour could be bounding and intense. You know, you always want to palpate their radials simultaneously, at least. I mean, you could probably palpate. Can you take your watch off for me, ma'am? You could. I mean, I would probably palpate. Did y'all do it like that last year? You palpate everything simultaneously except the carotids. So everything palpates simultaneously except the carotid arteries. So tell me which one I need to do first. I'm gonna let y'all tell me. Here we go. Carotids we've done. Yep. Then what are we palpating? Radial, thumb side. Ulnar, pinky side. Brachial is kind of right up in there. Same thing you would obliterate for blood pressure. Kind of grab her like that.
Midline abdominal.
Yep. And then you just use one hand, midline abdominal, for her aorta.
Verbalized femoral.
Yep.
And then the popliteal.
Popliteals. The feet are the fun ones. You guys, I don't know how you guys all feel about feet, but just get ready. Because you get to get comfortable with your patient's feet. And people don't take care of their feet like you take care of your feet. So the dorsalis pedis is right about there. You just kind of find the first metatarsal, and you're just kind of right medial to it, just right there. You know, you just have to practice. And then posterior tibials, again, should be right behind the medial mouth.
have cankles. It's hard.
Yours are good.
I was going to say, is my foot dead? Because I can't feel
But you can, again, you
I
can
can't find my ulnar either.
You can palpate all these at the same time, you know. Practice feeling them. I mean, sometimes on the SPVL you're going through the motions, you know, just try to get all your spots covered. But, you know, practice, because it takes varying amounts of pressure to feel them.
Sometimes if you can't feel it at all, just try and like let way up and start going slowly in.
Because you may be pressing so hard that
You're occluding it. Teach your fingers to see and feel. Both hands, not just one.
So once we feel it, we can move on. There was enough time.
yeah, and with the SPs, and like with the SPs, you don't have to verbalize all this because they know what you're doing, but you can just remember to verbalize, okay, I would do your femoral arteries, but I'm gonna skip over those. And then just, to me, palpating for edema is pretty self-explanatory. I mean, you just mash. Just kind of mash for 10 seconds or so and see if she has any. I would always check up here and down here.
And when you get it down here, you should continue to creep up because you should document where that stops. 1+, 2+, pitting edema, left lower extremity or bilateral lower extremities to mid-shin, or 2 inches below the knee, or all the way up into the thigh,
Yeah, and
all the way up into the abdomen. That paints the picture for the next practitioner coming on to be able to compare. Any questions?
Anybody want to see venous pulsation? You can come see my neck. You want to see what it looks like. Professor Reggie. Is this live actually? Yeah, it is. So you don't want to find it?
You know what, I'm just gonna stand up on the table. You guys watching?
So when you see pulsations, you want to palpate and see, is that the artery I'm seeing, or is that venous? By palpating, if it doesn't have a pulse, it's venous.
Especially because she's so thin.
Lay down.
Is it distended?
Yes. It's like wide. Yours too. What the heck?
Oh no. Wait.
Right? Yeah, yours is kind of blind. I can't tell if it's holding on to it. Yeah,
it's
yours
totally
is doing
focused.
just what hers is. Caitlin's does it too.
Do I get an award?
You guys need to practice on each other. When you are testing and going through those pulses, if you're having a hard time palpating, for time constraints, again, because you're
Oh my gosh, yours are rotted. Wow.
Close enough.
definitely practice that you know where they're at. Popliteals are extremely hard.
Anybody want to see where it
Oh, that's more than likely you're not going to palpate. You're on this one.
Women's size 7. Was it really that bad? Who was that dating? You did mine on the way out. Oh my god! Such a compliment.
What do y'all look at? Oh,
I also have small feet apparently. Everybody's poking him prodding me.
Do you want to say hi? Oh, yeah.
That's a big one. I yelled at us like, oh god.